Can you all see the screen?
Yes, please.
Yes, sir.
Tell me what is written there, if you can see.
Anatomy of the pelvis.
Anatomy of the pelvis.
Osteology.
Osteology.
Garden
BS imagery.
Okay, good.
Yes, midwifery.
Okay, so it means that you can see. So this is what I loaded there. The idea here is that from the conversation I had with you,
Yes, sir.
from the conversation I had with you, it means that I'm starting basically from the pelvic, the bones. Let's start that. So I gave you the PowerPoint to go through so that when I come, I won't waste time. You have your question, you ask, I explain, and we go. But it seems that it's today that a lot of you are joining. So group B, you are one. If you do that again, if I put something there, and that day that I'm going to teach, it's not that you are joining. Okay? Remember the way you were joined. I can easily pick A from B. I know what is A. A is purely Kumasi, and then some part of that Entakrati. That's all. So please be one. If next time I tell you something in class and you don't see it, be on your reps, be on their neck. Some reps are too relaxed. Be on their neck. The lecturer said he will do that. Has he done it? If he said no, the person will remind me. Okay? Is there any question on the PowerPoint? If you've gone through, is there any question? Or you will not look at it, those of you who downloaded it. Hey, any other chrono? Okay, let me go through. But today is your first and last when I put a PowerPoint there and then you don't go through to ask me questions. Today will be your last, okay? Okay. Now, with a pelvic bone, there are names that I'm expecting that you know already. Like this. Can you see the cursor?
Yes, sir.
Can you see the cursor?
Yes, sir. Yes, sir.
And this word, the oskose, the innominate bones, okay? The hip bones, they are the same thing. These three terms mean the same thing. Now, when we talk about the hip bones and the bony pelvis, they are two different things. I'm repeating it. Hip bones and bony pelvis, they are two different things. Or at times we call it the pelvic girdle. The pelvic girdle. Okay? So pelvic girdle is the same as hip bone, is the same as the oskose, is the same as the innominate bone. But when we talk about bony pelvis, it's different from the pelvic girdle. Anybody who can tell me the difference between bony pelvis and pelvic girdle? Anybody? You raise your hand first, please. Or you can type it. Yes, Dorcas.
Hello, sir. Good afternoon. Sir, keep quiet, I'm learning. Sir, please, the bony pelvis consists of the two innominate bone, the sacrum and the coccyx. And the hip bone is only the two innominate bone.
Okay.
That's what I can say.
Thank you very much. Okay, Dorcas, thank you very much. Okay, good. So I hope you've heard the difference. Okay, one has to do with the innominate bones. So when it comes to the hip bones, which three bones do we call hip bones? Or they're not the oskose? There's three bones fused to form one. Can you mention the three bones for me? Yes, Janet. Janet?
Sir, ilium, ischium, and the pubis.
Okay. Now I'm going to show you pictures. And then you tell me which one is ilium, which one is ischium, and pubis. And at your level, I'm not interested in the whole bone, the parts of the bone. Because clinically, we use these small parts to do so many things. Okay? So I'll be interested in the parts of the bone. Okay? Okay. Adina, also 93. Brown. Dinah Brown, please mute yourself. This time, I just want you to talk, but it seems
please mute them.
Now the whole class is muted. I don't know you adult, but really, the way you behave, I like and things I don't like, but it seems you don't care. Let you talk. When you want to talk, you raise your hand. I will unmute you and you talk. Okay. So that's what I'm going to do. Okay, let's go on. So it is good that we know it. Now, for the first statement there, the 3 bones have been mentioned. The second paragraph and the third paragraph is important. Now, can you look at the second paragraph on your screen? The second paragraph says, at birth, each of these 3 primary bones are joined together by hyaline cartilage centered at the acetabulum. Now, hyaline cartilage has come through. Now tell me, how many types of cartilage do you know? And let's look at it carefully. These are things I'm expecting you to know. Hyaline cartilage. How many types of cartilages do you know? If you know, you raise your hand. Any idea? Type of cartilages? Any idea? Yes, Janet, let me unmute you. Keep raising your hand.
Hello, sir.
Yes.
Hello. Sir, please,
yes,
I know of the elastic cartilage.
What
and
again?
the fibro cartilage. And the hyaline cartilage. And the hyaline cartilage.
And what again?
That's all that I know.
Okay, Janet knows hyaline, elastic, and then fibro. Now, can you tell me where we can find fibro in the body? Any idea where we can find fibro in the body? Let's say I have Josephine. Josephine, your hand is up. So Josephine, you can talk. Any idea where we can find fibro in the body? Josephine, you can unmute yourself and talk. Josephine? Okay, I think Alberta. Alberta, you can unmute yourself. Alberta, you have the floor. Okay, nice. Barbara. Barbara has written almost like something from. Okay. Let's see what Barbara wrote. That drew my attention. It said fibrocartilage is that. Okay, no. Like the pubic symphysis, the intervertebral disc. Barbara, is it from Google or from your head? Barbara. Okay, let me allow you. Barbara. Oh, okay. Don't give me definition or examples from Google. I'll catch you. Okay. Okay, I already said from the spine and from the knee. Fibrocartilage. Gifty.
Yes, sir.
Gifty?
Yes, sir, please. I think it's from the connective tissue.
Okay,
the yeah.
Yes. In fact, all cartilages are connective tissue, my dear. All are connective tissue. But they are found. Now, let me give you an example to help you out. Fibrocartilages are found in the midline of the body. Midline of the body. And then they are also found in area that we need tensile strength. Okay. So if you look at the midline of the body, like the intervertebral disc, okay, people carry things on their head. So the intervertebral disc, the cartilages there are fibro, very hard. Pepex emphasis, midwives, is fibrocartilage. That is why dilation is difficult and then it's painful. It's fibrocartilage, okay? In the midline of the body, when you go to the scar, there's so many areas we have fibrocartilages fused, okay? Elastic. Where can we find elastic? 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 Elastic. Dorothy say the ear. Sadia saying the ear. Beatrice ear. Alberta lungs. Ernestina body joints. Barbara ear. Sylvia say epiglottis. Jacqueline ear. Vera ear. And then we have Juliana also saying the ear. Alasan say elastic of the external ear, epiglottis, nose, inis, linear larynx, aorta larynx, and then wonderful. You are all saying almost the same thing. Okay. Now another question: which of these ones can be transformed to bone? When a baby is born, does he have bones? You are midwife. You delivered babies. Do they have bones when they are born? Do they have bones? When a baby is born, do they have bones? Yes, Dorcas.
Yes, sir.
Do they have bones? Yes or no?
Yes, sir. Sir, they do have.
Okay. And some of your colleagues too are typing no, no, no. Others are saying yes. So there's a divided attention here. Now, please put your hands down and let's vote this one. Those who believe that babies have bones when they are born, hands up. Babies don't have bones, hands down. Let's see. Baby have bones. Let's see, hands up. Babies, when they are born, they have bones. Let's see you. I have 677 people online. So let's see. Baby have bones. Let's vote. No bones, hands down. Yes. Bones, hands up. No bones, hands down. 230. Wow. Are saying babies have bones. It's still going on. 240. So it means majority are saying they don't have bones. 250 now. It's still ongoing. I'm saying let's vote. Stop typing. Vote, vote, vote. If they have bones, you vote. If they don't have bones, you put your hands down. Now 260. Will it go to 270? 270. 280 now. 290. 290. Will it reach there? Oh no, it's not reaching 290. 290. That's right, 290 now. So 290 students out of 674 are saying babies have bones. Stop typing and vote. That's all. Stop typing. Just vote. Okay. So I will take it approximately 290. So out of 679 students, 290 are saying they have bones. Can you put your hands down? So it means about 300 and something students believe they don't have bones. And this is a class of midwifery. Put your hands down, please. Now think about it carefully yourself. Think about it carefully. Now they pass through the vagina out or through CS. Fine. Now let's look at those that pass through the vagina. Do you think the scar at that time is bony? Now let me reframe my questions. The scar is bony. During delivery, the scar is bony. Those who believe the scar is bony, hands up. Scar alone. Let me reframe the question. Scar is bony, hands up. Let's see. Scar is bony, hands up. Scar is bony, hands up. I have only 31. The scar is bony. Interesting, very interesting. These are midwives who have practiced for at least 1 or 2 years. People have practiced, last time we saw that people have practiced for more than 5 years. And this is a question I'm asking you today. Is the scar bony during delivery? I have only not even 200. It means a lot of you are confused. If you're in the delivery room, please go and check. Hurry up and check. Because those typing, I still get no, yes, no, yes, no, yes. Wonderful. Midwives. God. Okay, so I have 200 are saying the scar is bony. So I have about 475 who think the scar, interesting. Interesting. Wow, interesting, really interesting. Wow. Oh, when I say raise your hand, we have a place to raise your hand. So go there and raise your hand. Now it's 207. 207. Okay, now let's go. So I have the data. Minority of you thought that the babies don't have bones. And then very minority also think that the scar is not even a bone when you are born. Please put your hands down. Put your hands down. It tells me that I have work to do. A lot of you have doubts in their heads. A lot of you have doubts. They doubt the answers. People cannot even raise their hand. They are not sure. So put your hands down, please. Everybody put your hands down. Hands down, please. I want to get 0. Hands down, hands down. And let's start explaining things before you start saying things that does not exist to people. But before then, I want one person to explain to me why they have bones, why the scar is bony. And then one person also explain why it's not bony. Who will take why the scar is bony? Justin, Sandra, Sonia, your hands are already up. You can talk, any of you. If you want to explain why the scar is a bone or is bony? Sandra? Gloria?
Okay.
Yes, who is talking?
Sir, it's Dorcas.
Yes, Dorcas, go on.
Sir, the scar is bony because it will protect the brain of the baby. So when it's that's why when the baby is coming, we do the VE. We say that it is overlapped or something like that. So it will protect it. If it's not bony, if it's not bony, then the brain can be damaged through the procedure. That's what I know.
So Dorcas is saying the scar is bony because she has touched one before. She has touched one before, so it's bony. Good. Any other person to take the other way around? It's not bony. It's not bony. There were many.
Yes, it's bony.
Anybody? Who will talk for that? It's not bony. Rose, your hand is up. Anita, your hand is up. Who is talking? Otibwaten,
my hand was up for bony, not bony.
So please, those that their hands are up for bony, they should put everything down. We are looking at not bony now.
Okay.
If your hand is up for bony, put it down. If it's like now, we are looking at not bony. Okay,
Sir, please,
patience.
not Bonnie.
Yes, go on, my dear. Asantua, go on. Why?
Sir, it's not. Sir.
Asantua, I couldn't hear
Hello,
you. Can you take
sir.
that? Yes, go on, Asantua. I can hear you, Asantua. Go on.
It's Stella.
Okay, Stella, go on.
Sir, I think the skull is not bony, and other bones, other fetal baby bones are not bony because they are cartilages. Because babies get they completely break down or break. I think after time they develop into
I say 130
something
initial,
else.
30 citizen. Yeah, my who? Items another.
Hello.
Yes, go on. You see, your explanation were giving, it was not complete. I couldn't hear you well. So can you take it again?
Okay. I said I think the bones of the neonates they are rather cartilages because if a neonate or a newborn baby had fracture, it's not those fractures like the other bony. They are rather cartilages before they develop into bones, strong, ossified into strong bones. Thank you.
Okay. So that is also her take. It is not a bone. Can some people want to talk? Rebecca, do you want to talk?
Sir, I want to
Add
talk.
more, Rebecca.
Yes, sir.
Okay,
Sir,
go on.
I'm in support with his bone, but I just want to try to explain for not a bone.
So where are you? Bone or not bone?
Bone.
You are with
Bone.
bone.
Yes.
So you're explaining for bone. Okay, go on.
No, I'm explaining for not bone.
So are you not bone or bone? Now, you have to take a decision, my dear.
I'm for bone.
So you are explaining for bone. Because you can't be for not bone and you want to explain for not bone. What is that? I don't get it.
Okay.
So make
Let
a
me
decision.
explain for not bony.
Okay, go on.
It's not bony because it's not ossified, and then when the baby is coming out from the vagina, the frontanels overlap for the baby to be able to come out, and then the one who explained bony was like it covers it to prevent brain damage. But the truth is, if you should use vacuum or forceps, you can easily cause damage to the brain because it's not bony and it's not ossified. Thank you.
Okay, thank you.
I wish to talk.
Hello, sir.
Yes.
Hello,
Who want to
sir.
talk? Raise your hand. Raise your
Anita.
hand.
Find hand is up. You're not mentioning her
Sir,
name.
my hand
She
is
wants to
up.
talk.
Anita.
Anita.
Yes.
Okay, Anita, go on.
Sir, I'll go for Bonnie.
Okay, go on.
Because during when we were learning the fetal scar, we said calcification begins as early as 5 weeks following conception. So it starts like a cartilage, and calcium will act on it and it becomes calcified. But leaving some membranous spaces that we call it the fontanelles. So it does membranous spaces that will help the bone to overlap for the head to come out during molding. So I'll go for bony because the chief function of the skull is to protect the brain. So if it's not ossified, how is it going to protect the brain? So during the forceps delivery that the lady is talking about, because if they know it is only membrane, how are they going to use the forceps to deliver the head? But because it is calcified and it is bony, that is why they can do the forceps delivery. But the membranous spaces that is not calcified, the fetus come out before it will be completely calcified. Even the fetus can grow can go to some level, I think 25 years or so, before it will become completely calcified. So as the fetus grows or the baby grows, the membranous spaces will gradually become completely ossified, but it's bony and it's calcified, and it starts exactly 5 weeks following conception. So it's bony. Thank you.
Anita, politician. Speaks
Okay,
here.
sir, I wish to speak now.
Yes. Feza,
Yes.
go on.
Just like Anita said, the skull bones, the fetal skull is actually comprised of bones, and these bones protects the brain. And just like she said, the development of the fetal skull starts as early as 4 weeks following conception, and by the 5th week, calcification begins in the ossification centers. So this is why let me relate it to something. In preterm deliveries, we realize that they are liable to damages to the brain and other structures, because these bones are not ossified that much. But even with the ossification, there are some areas of membrane that is left out. This helps the head to overlap during delivery so that it can easily pass through the birth canal. So that is why we have the sutures, and where the sutures meet, we have the fontanelles. So, and we can also relate it to post-date. After 40 weeks, when these bones are more ossified, it becomes difficult for the head to pass through the birth canal because molding becomes difficult. The skull bones finds it very difficult to overlap. That is why in post-date too, we easily have trauma to the maternal perineum and other things. And even, let me correct something. The skull bones, unlike other bones that start from that begin as cartilages, the skull bones begin as membrane. It starts from a membrane and not a cartilage. So this is the correction I want to make. Thank you, sir.
Okay. Nice. Anita, Feza. Those not born people, have you given up? Have you allowed these ladies to confuse you? Have you given up? There is no bone. Or now you've accepted them. No bone people, have you given up? Or you can talk.
Yes.
You've given up.
No.
And sir, if there are no bones, how do we have the clavicular fractures and other things? Is it not bones that we fracture?
Please. Okay, Feza, you made your point. Let them also speak. I'm democratic. There's no bone people. Is there another person?
Point there.
With what she said, with the clavicular fractures, they are not fractures, they are just green stick fractures.
So you've given up.
Silence me.
Oh, just like that. Vida, your hand is up. Vida.
Yes, sir, please. I wanted to say that it's a bone because I saw one. I assisted one doctor doing IUFD and he crushed the baby's head and I saw bone. That's why I'm going for bone. It's bony.
This one there is from vision, observation. She have seen it, so she can't deceive her. She saw bone. Oh, is that so? You be giving up? No bone people. Rebecca, your hand is up.
Yes, sir. Sir, it's bone because even during delivery.
Please, Rebecca. I'm one of those who say there's no bone to also talk. The bone people, you talk a lot.
Okay.
No bone people, you still have the floor. Defend yourself. Don't allow them to just say things and then you are there. No bone people. Have you given up?
They are sleeping at this moment.
Said they have given up.
Christiana, your hand is up. Christiana.
Yes, sir.
Christy.
Yes, sir. Sir, myself have delivered a woman who has a baby, let me say fetus that died in utero. And before the baby is delivered or the fetus comes out, the bones in the head, everything, I don't know, but it's like everything gets loosed. So you can feel the head that there is bone in the head. So if there are no bones during the time of forceps delivery itself, why would they apply the forceps to hold the baby's head? So I go for bone because I know, as my previous sisters have explained, the sutures and the frontal allow the overlapping of the.
Oh,
yes, sir.
Yours,
So I'll go for bone.
Hear anything on bone again. I wanted to hear those with no bone issue.
Oh, okay. I go for bone.
So no bone people, you've given up. You've accepted bone people.
They are not around.
But they have given up. Let's.
Oh. Majority, yeah, in a ratio 1:2. And they've given up just like that.
We've chased them out of class.
Okay. Now that, let's see what people have written there. Since now people have run away, let's see those who said no bone. Oh, no bone people. Oh, you've not done well. It's not good. You don't debate like that. You don't run away. Okay, good. Now let's think carefully to point 2. Point 2 was talking about hyaline cartilage, okay? And we said that the hyaline cartilage joins the bone together. So it's a statement. Join the bone together. So I intentionally still ask you that question, okay? So it's the hyaline that joins the bone together. So what you could have said was that the cartilage makes the joint, the sutures, very weak as compared to when the baby is born, okay? So in vivo, your joints, your sutures are weak because it's cartilaginous, okay? But bone, there is bone, okay? So when you look at the third point, can somebody read the third point for us? The third point.
Yes, sir. Fusion begins 15.
I want someone to read the third.
Sir, fusion begins 15 to 7 years and completes 20 to 25 years. Thereafter, no trace of the fusion line can be detected.
So here we are talking about the pelvic, okay? We say that the oscosy, the 3 bones, that's the ilium, ischium, and pubics. Now, when you are born, this is not completed. The fusion of these 3 is not completed. Who's on? Christiana, your hand is up. Christiana, is there anything? Christy, your hand is up.
Hello, sir.
Yes.
Please, this is Michelle. Please, Faustina is giving us a lot of feedback, so I can barely hear you.
Faustina.
I don't know if you can mute her.
Let me mute everybody. Actually. Okay. Who is that Faustina? Okay. Good. Christiana, your hand is up. Is there any problem? Christy?
Yes, sir. Sorry, it's the previous one. Sorry.
Okay, good. Now put your hands down for me, my dear. Okay, so what we say is that the acetabulum area that forms the joint for the 3 bones, the fusion of it even starts 14 to 17 years. So let's take a baby girl born. When she reaches 15, it's not that hip or the acetabulum joint, that vinegar cap joint is fusing. So it means that below 14, the hyaline cartilage effect is still 20 to 25. So when you are 20 to 25 years, that is when this line is fused. Now, this brings about these 2 categories of people. under 14, under 15 years. Who has delivered somebody under 15 before? If you've delivered somebody under 15, was it difficult as compared to somebody 45? Yes, Frida.
Hello, sir.
Yes, Frida. Yes.
She was able to deliver normally, no problem.
Okay. So is that Gifty or Frida?
Come again. Hello, sir.
Yes.
I can't hear you.
Oh, that Frida, I was asking, have you delivered somebody under 15 before?
Yes, please. I think
Okay,
the
and was
youngest
it
I've delivered was 12 years.
Okay, and she was able to give birth nicely, vaginally.
Yes. Actually, she was for CS, but she came later in second stage, so she delivered.
Okay. And then let's see, Gifty Johannes up. Lydia Johannes up. Gifty.
Yes, sister, I did sir, please, I delivered one 14 years. She was 14 years old. It was a normal delivery. She didn't have any complications. We just gave a piss. It wasn't even a big episiotomy, and the baby wasn't that big too, so that also helped her.
Okay.
The fundal height wasn't here. Yes, please.
Okay. Yeah. Lydia. Lydia.
Sir, yes, sir, please. The one I also delivered was 14 years. To me, it was
Anita.
so easy. I felt it was easy compared to the adults, compared to from 18 years and above.
Okay. Anita.
Hello, sir.
Yes.
Yeah, all the knowledge that I've delivered, the 14 and the 13 people, they find labor very difficult. Sometimes they can't push. Sometimes you even have to do fundal pressure or give episiotomy, do fundal pressure before they can push. For me,
okay,
that's what I've experienced. As compared to yes, as compared to those who have delivered before, those people find labor very difficult than.
Oh no, please, Anita, I'm not comparing that way. I'm comparing
about
first delivery for somebody that is 14, below 15, and first delivery for somebody who is 45. That's what I'm saying.
Oh, okay. And for first delivery 45, I've delivered some before, but for the 14 I have, and it was difficult though.
But they were able to deliver vaginally.
Yes, they were able. Just that they can't push. Sometimes they can't push.
Okay, good. Okay, that's nice. Christiana, do you want to say something so that we close that chapter?
Yes, sir. I've also not delivered 45 before, but 13, 14, 15 years I do. Some of them have severe perineal tear. Even though you were trying to help them with episiotomy, but before you realize, oh, these children, the way the tear happens is too much. So if the head crown and I realize that the way the perineum is shining, things will not go well. Quickly, I have to give episiotomy because the first experience I had with the lady, it was too bad. So with the 45, I can't tell, but they are pushing. It's a problem, like Sister Anita was saying.
Okay.
When you ask them to push, they don't know how to go about it. Thank you.
Okay, good. So let's come back to our statement. Now, that statement is saying fusion begins 15 to 17 years. So it means if somebody is under 15, the acetabulum joint is still hyaline. So hence can open up easily to the hip. Okay. We say this completes 20 to 25 years. After 25 years, it has fused, it's bony. So if somebody is 45 and that's the first delivery, it means this one has been there for almost 20 years. Okay, so we are talking about the hip joint here. Please don't get confused. That's tabulum joint. Okay, it's bony after those years, and then those below 14, because those joints are still cartilaginous, together with the other joint that we needs to open. Mostly delivery, if it's not tear, delivery, the bony aspect of theirs is good. Okay. But if more, so if you deliver somebody that's under 14, and then apart from tear issue, and at times another reason is psychologically. You midwife, you frighten them. I've learned even when they come for antenatal, you frighten them. At times they also feel shy to mingle with the others. So there's a type of fear in them. So when I come to deliver, they keep quiet and suffer. They are not, they don't waste much of your time as compared to our own married women who be crying and making noise for the husband to come. Okay, so if I take that psychological aspect off, they are supposed to do well. If you come to dilation of the bone, not the tear. The tear, they will have disadvantage there. We're going to look at it later. Okay, so that is the aspect. So if you are dealing with somebody that has been more than 25, let's say 30, 40 on, and that's the first delivery, there's also a trouble based on the bone, not on the muscle. Okay, based on the bone. So this is the point I want you to take or to get it. Knowledge of the bony pelvic or the hip bone is important to understand these ossification factors at the acetabulum. Remember, the age, it begins 15 to 17 and then ends between, for those that will begin 15, it will end at 20. For those that begin 17, it ends at 25. So if yours begin at 16, it's possible 21, 22, it will end. Okay, so this is where this, and in terms of RTA, road traffic accident, these people below 14, if you get a problem to their hip joint, because theirs is cartilaginous and it's not fused completely, healing is also easy as compared to those of us that will be older, that is fused already. If there's a problem, healing becomes difficult. Okay, so in terms of road traffic accident healing, age is important when it comes to that stuff. So it means when you have an old lady getting a problem at the hip, there is problem. There is a big problem because osteoporosis and other factors are setting. Okay, so this is what I want you to take note of. Okay, I have 3 hands up. Who and who? Or is the old hands, because I can still see the same names. Anita, is it something different or is the old hand? Anita?
Yeah, the old hand, sorry.
Then put it down. If not, you confuse me. I think it's something different. Okay, let's go.
Sir, I have a question.
Is it Frida? Go on. Frida, go on.
Sir, with what you are saying, then I think that below 15 to are predisposed to food drop.
Oh, yes. I'm there. Hello? Oh, this rain will disturb my class today since it's raining everywhere. Okay. Who are those? Meet everyone. And I'm surprised when you meet them, they will meet themselves rapidly. How? Okay, let's go. So these are the points. You should understand it in terms of accident, road traffic accident, and then you also understand it in terms of delivery. In your case, delivery matches all. Okay. Now let's look at the pictures. Now, stability of the joints of the pelvic girdle is also helped by ligaments. So if you know the ligaments too, it helps. So if you look on the front picture or the superior picture, these are the colors to show the bones. Okay. Now, this particular hole, how do we call it? Where the cursor is? How do we call it? Yes. How do we call that hole? Yeah, Dorcas.
Sir, acceptable.
Acceptable.
Please look at it carefully before you talk. I'm talking about this.
Obturator foramen.
Obturator foramen.
Sorry. Obturator foramen. Obturator foramen.
Okay. Thank you for seeing the right thing quickly. The first lady was taking a part. She was looking at something else. Okay, good. The obturator foramen. That name is only in the skeletal system. In the living, it's not a foramen. I hope you know that. In the living, how do we call it? In the living, how do we call it? It means when you are not dead, this place is not a foramen. It's not a hole. It's covered. So in the living, how do we call it?
Obturator membrane.
Obturator what? Obturator membrane. It is the membrane that covers it. So it's no more a foramen. The name changes. So it's not membrane. Okay, it is the membrane that covers it. So now, instead of saying obturator foramen, we say obturator. Obturator what? Yes, we say obturator what?
Please say obturator magnum.
No. Try harder.
Obturator foramina.
No. Foramina means smaller. Please, no.
Sir,
Yes.
please
Obturator what?
Internus.
No.
Hey.
Midwife of way. Midwife of way. I'm waiting. Midwife is your area. Come on. Obturator foramen is only a skeletal system. In the living, we don't call it foramen. There's a membrane there. And the whole thing is called obturator. Hey.
Membrane.
Is it greater sciatic area?
Hey, please, please don't go there. Don't go there. Don't go there, please. You have not read there yet. Hey, so midwives, this is your
obturator membranous. Obturator
membrane.
Canal.
Membrane. Now listen, it is the membrane that covers the thing, the foramen. So now it doesn't become a hole. It becomes a what?
Canal.
Yes, somebody said it. It becomes a what?
Obturator fossa.
A fossa. Fossa means a depressed in small. It's not a hole, it's a depression. So it's in the living, we have obturator fossa. That superior part of it contains a small canal that allows the obturator nerve to pass through. So the obturator fossa will have the obturator canal that allow the obturator nerve to pass through. Okay. So take note that in the living, at times these are things that separate us. Okay. And a midwife would just say obturator foramen. But please, in the living, we don't have foramen. Foramen is only in osteology. In the living, it's obturator fossa. Okay, obturator fossa, and then on top of the fossa. So if this, look at the cursor, if this is the fossa, then on top of it here, we're going to have the canal that allows the obturator nerve to pass through. Okay, good. So now what about this line there? Now, if you look at this part, you tell me the part and tell me the clinical use of each of them. This one, you've delivered people for long. Okay. So now let's start from here. The iliac crest, what can you use it for in practice? Iliac crest.
For measure.
Iliac crest.
Are we even closing at 12?
Sir, we can use it for measurement of the.
Can you raise your hand first for me so that I will see you? Can you raise your hand first for me? Rebecca. Yes, Rebecca, go on.
The iliac crest is where we put our hand to support when we stand.
Okay. Supporting of the hand. What again? What again? Iliac crest. In practice, what can you use it for? So you see, I'm interested in the part and practice. So if I should ask you any part, please, I don't care about you knowing the name. I just care about what we use it for. Rita.
Sir, please, for pelvic measurements, you can use it for pelvic measurement too.
Like how? The iliac crest, how? My dear, throw more light on it.
Like during palpation, most of the, like when we are able to locate the how do they call it?
Symphysis pubis.
No, not the symphysis pubis. You know, when you are palpating for the is it, they always say the anterior shoulder. So when you are able to locate it, that is where we rest like our hands on the pelvic, the iliac crest.
Hey, what are you saying? I don't understand you. You can speak in all language. I've told you. Any language you want to speak is allowed. Yes. Rita.
Sir, please, let's go.
Okay. Sarah?
Sir, sir, please, the iliac crest is used to rotate human hip. It's used in the rotation of human hip.
Doing what? When do we rotate somebody's hip?
During movement.
Like you are moving to somewhere, you are use your crest to rotate, like catwalking. Is it what you are talking about? Catwalking.
Yeah, turning your back, like turning.
Like catwalking, modern walking. Is that what you are talking about?
Yes, sir.
Hey, so Sarah, when you are walking, you can intentionally hold your iliac crest and then
No, sir, don't hold it. It helps. You won't hold it.
So it helps. No, I don't get it too. I don't get it, Sarah. I'm trying to picture what you are saying, but I can imagine you walking and then you are twisting your like, I don't get it. Like how? Hey, Sarah, can you feed Mentias? What's it?
Hey, like it's so like a boy turning.
Sarah, do you know where we call the crest? Look on the screen. This area, that is where we call the crest. So, like, I didn't see so. That is labeled there. Yes, Janet. Those typing, most of your answers are wrong. Those typing. Support of the abdominal organs, attachment point of muscles, attachment point of the muscle. Yes.
Hello, sir.
Yes, go on.
Technically, when they want to perform lumbar puncture, they use the iliac crest to really find out the level of the fourth lumbar vertebra.
Thank you. That is one of the use in clinical practice for lumbar puncture. When you are going to do CS and they want to give you anesthesia at the back, the anesthetist will use your crest to measure to the back where the thumbs will meet. That is where he will inject. Crest usage, that's one of it clinically. Now start talking. Thank you, Janet. You've opened the gate. Let's see if people can add up. So you are practitioners. When I say the use of it in clinical use, please go clinically. So in lumbar aspect, yes. Gifty. Gifty.
Yes, sir. Yes, please. That was what I was about to say. That helps you to locate the fourth and the fifth lumbar vertebrae, so as to help to give an injection during lumbar puncture. Yes, please.
Okay. I have Aisha to say it provides attachment for the hip flexors, the abdominal muscles, and the muscles that rotate the hips. So actually, it is attachment of muscles that rotate the hips. It's not you walking and want to rotate your hips. You can't do that. Okay. Georgina, say it makes the upper part of the hips. It marks the upper part of the hips. Well, it's true. Portia, I say for movement of the hip during labor. During labor, movement of the hip. How? I'm trying to picture it. Portia, can you throw more light on it? For mandibular reconstruction. Hey, no. That's surgery. You go to Google and pick an answer. Justina, Ifua.
Hello, sir.
Yes.
So the iliac crest, I like sometimes the doctors also use it for bone grafting because it has a lot of bone at its surface. So they use it for bone grafting in some cases.
Yes. Yes, we can borrow it for bone grafting. Yes, we can borrow part of it. Yes, that's true. So please, ladies, this is how I want my answers. Given the part and given the clinical use. Now let's take two more and then jump this area. The anterior superior iliac spine. And then we take the ischial spine. Anterior superior iliac spine, what do we use it for clinically? And then we take the ischial spine. What do we use it for clinically? Yes, these two. So next time when you take this slide, you try to know all the clinical use of these parts. You'll be amazed what you can use it for. It's not only for push, we use it for other things. Yes, anterior superior iliac spine and then ischial spine. Yes, Gifty, your hand is up. Gifty?
Sir, please, it's the old hand.
Then put it down. Clara?
Yeah, good afternoon.
Yes, afternoon, Clara.
Iliac spine, I think it's for the attachment of muscles. And then the sciatic spine, the ischial spine divides the greater sciatic notch and then the lesser sciatic notch.
And then that division, what will it do clinically for us?
It will help you know the station of the baby.
Now that you are talking, but that division that we are talking about.
If it's
Clara, come again. Now put your statement clear.
Sir, please, I said the
Clara?
iliac spine there. The ischial spine divides the greater sciatic notch and then the lesser sciatic notch. So if it's prominent, it means there is a reduction in the pelvic outlet. And if it's not prominent, it means there will be sorry. It means the woman will be able to deliver without any problem.
So which one will allow easy delivery? Prominent or no prominent?
not permanent.
Okay. So then reconstruct your statement, Clara. So the ischial spine is a guide.
It's a guide that lets you know where the baby has reached. If labor is progressing or not. And it's a know if the woman will be able to deliver through vaginally or not.
Okay, good. So that is how I want my answers. Okay. What about the anterior superior iliac spine? Any idea, Clara?
Sir, please, I said for muscle attachment.
Any idea of the muscles? Any muscle in mind? Any muscle? This is BSc, my dear. Any muscle in mind?
Sir, please, I've forgotten them.
Now go and get it back. Because muscle attachment, I want to accept that answer. I want a specific. Justina, Johannes.
Sir, please, I wanted to add a little about what my sister said
Justina.
about the ischial spine. So I said, it is also used to assess distance during labor.
To assess the
distance of the fetal head during labor.
Okay. Okay. Yes. Okay. So you see, ladies and gentlemen, this is how we want the answers. Okay. So if I give you parts of the pelvis, like the arcuate line, what is it used for? That's what I want. The peteneal line, the pipid tubercle, the articulation surface of the sacrum.
Thank you.
You see, so take your time and then know these parts, what they are used for clinically. Okay. Now, one thing that people don't usually talk about, ischial spine. Ischial spine. Ischial spine. Oh.
It's left for to even if it is 5 minutes.
Nafisa, Nafisa, if you don't want to be in class, keep quiet, okay?
Yeah.
Okay. So the ischial spine, for instance, it helps to block nerves. Have you done block? Have you seen any ONG person doing blocking for a lady in labor before? Blocking means we can block the labor pain by 50%. Have you seen it before? Have you experienced or taken blocking before?
Yes, sir.
And how was it done? Yes, how was it done? If the labor pain is too much, you can block it. Usually the ischial spine. How is it done? Yes, Rebecca, how was it done?
So, for example, the anesthetist. So during it's given to the neck. Make that place to be numbed. So all the contractions and the pains will stop because the patient.
How will he do it? How will he do it? Take your time. How will he do it?
So it is the anesthetist's own that I observed.
Yeah,
is given at the spine and around the sacrum.
Oh.
The fourth and the fifth vertebra. So when it's given, it blocks the nerves for the client not to feel anything. So mostly they feel numbness
I'm talking about using the ischial spine, Rebecca, ischial spine to block.
Okay.
That injection, the anesthetist hand will be through the vagina. Have you experienced that before?
No, please.
You never seen people blocking. We can block and do normal delivery. If the person in too much pain, we can block it 50%. Okay. Then I will have to load the video for you to watch it. How it's done. Use the ischial spine. You go through the vagina. Naturally, you will feel the ischial spine. Then you inject the opposite side along
it. 2 weeks.
Why? Because
Them who
week is that.
in the pet. So it's my bed, not omuye when I know.
Dufie.
Abba.
Dufie, you pay some what? What even me too? Why we may wear free class? I don't know. But then when you may you free class, like empty class. What is that? Okay. So what I was saying was that the ischial blockage is important. You pass your digit through the vagina laterally. When you go to the vagina, you go to the lateral side, you feel the way you feel the ischial spine during delivery, the same thing. And then you inject the opposite side of it to the extent that the needle goes along it. We do it because the pudendal nerve, you see, the internal pudendal nerve, that is the master nerve for the muscles and uterus over there, moves on top of the ischial spine. So when I inject at that place, I block that nerve, hence contraction or pain that the lady is experiencing reduces by 50%. We do that for normal delivery. Okay, you block it halfway and then 50% because the ischial spine are two. You block one so that you can deliver with less pain. So if you learn well, you don't need to let your patient go through a lot of pain. You can block it halfway for it. I will load the video to your Telegram and look at it. Okay, we call it block. You can block pain, labor pain, so that at least the pain reduces by 50%. We use the persistent ischial spine. There's a nerve that passes on top of it, the pudendal nerve. On top of it. Okay.
So please, which drugs do they always use for that? Hello. Hello.
Yes.
Please, the drug that they use
in Ghana is done. In Ghana, we do this most of the times. We do it mostly. Just that you are not observant. Okay? So I will show you one of my videos. So that you look at it. Yes, go on. Yes, go on. Go on. On this platform, this is an embryology platform. It's not pharmacology. Not here. Okay.
Yeah, my hand is up.
Hey, fell left.
Okay, we do it in Ghana here. It's not Barakizu. It's not in anywhere. We can do it here. Okay, just that you need to learn. The nerve, as for the nerve, I'll tell you, is the internal pudendal nerve. Pudendal nerve is
talking about the drug, sir.
I won't mention the drug here. Come on. This is embryology class. It's not pharmacology class. I'm concerned to the
Sir.
I won't mention any drug here.
Hello,
if
sir.
I want to mention drugs, I do it on the page. Yes.
Okay. Sir, please, at what dilatation or at what stage in the labor do we give this? Do we block the pain?
When you can still feel the ischial spine, okay? Because you can't feel the ischial spine, it means the person can deliver naturally without you. After feeling the ischial spine for some time, doesn't dilate. The pain is enormous. People even opt for it. Some ladies will tell you, I want this. So you block it for them. It comes with an extra cost. Okay. So If you want to give birth, you can opt for these things, especially when you're giving birth in teaching hospitals, and this can be done for you. Okay, so that is why it's important for you. That's why I'm taking it from this angle. There are a lot of things in the pelvic or what we do you don't even know. So if you have time and look at these one by one, you'll be surprised that there are so many things we use these parts for. You're not aware. A lot. Okay. So let's take it. So please, with the pelvic part and the bone, take your time and look at it. Okay. So we are not here. I'm not like knowing the parts, that is what is important. No, but knowing their use is what I'm after. Okay. Like the ischial tuberosity, for instance. What do you use it for? Ischial tuberosity. Ischial tuberosity. This is the area we call ischial tuberosity, this portion. This is where we call the ischial tuberosity, the ischial part of it. What do we use it for? Any idea? Okay, sitting. Who I'm saying sitting. Apart from sitting.
Somebody rests on it.
Apart from sitting, what again? Apart from sitting, what again?
So the
That's
body
where we
is
sit.
the
body.
Where the body rests on.
Rest on it.
Oh, it's like sitting. Apart from that, what again?
For the
Apart from
attachment of
sitting.
gluteal muscles.
For the assessment of?
Attachment of gluteal muscles.
Okay, that's okay. But which of the muscles? Gluteal muscles are 3. Which of them? And the BSc talk to the end.
Muscle.
Maximum to ischial tuberosity. If maximum was there, I could be thrown now, so I can't just say whoa. Maximum moves up when you sit. It's not there, please. When you sit, have you sit on somebody's thigh before and the person is complaining? Especially as a gentleman sat on your thigh before, you can see it pricking you. Or a slim lady sitting on your laps. If a slim lady sit there, you can feel it pricking you.
The hamstring muscle of the thigh.
Okay, please take your time and do your homework. There's work to do. Okay, take your time and do your homework. So the parts that you see every day, it is an attachment for certain muscles. No, the muscle that attaches there. So when a patient complains, especially in pregnancy, people complain of so many pains there. And those things, you should know that, oh, if you sit and you have pain there, then it's from these muscles. It's not for this muscle, okay? The ischial, any part of the pelvic bone, there are a lot of attachment of muscles, okay? Attachment of the muscle. So this is the posterior view, and then anterior. Now, one of the bones coming sacral, the sacrum and the coccyx, very important bones. Please take your time and know the parts. Half of the parts that I know you know, but I'm interested in the clinical use. Now, during labor, how does it dilate? Which bones move forward? Which bones move up during labor? Do you have the sacrum, the coccyx, the oscosay? How does it move? Tell me the joint. Tell me the joint.
The sacrococcygeal joint. The sacrococcygeal joint. The coccyx will tilt backwards a bit to give way for the pelvic, for the fetal head to pass through.
Is it the only joint that moves?
Ligament.
Which other joint that will move? And I hope you know that which joint? Yes.
Symphysis pubic.
Symphysis pubic, yes, it moves how? How does it move? Posteriorly, anteriorly, like how does it move?
So it moves posteriorly.
Hey, are you sure? What's the use of that movement? It's moving to increase the pubic angle, okay? So how will it move?
It moves laterally.
Laterally.
Yes.
Thank you. Laterally. And what is the angle that is supposed to happen? What angle? At what angle?
90.
What's the constant angle for a female?
90.
For a female, the angle is supposed to
degrees.
be
90 degrees.
Please, for a female, it should be more than 100, please.
It's 100, sir.
So if you take your pelvic scan or an X-ray of your pelvic currently, and then we look at the pelvic angle and it's not 100 and above, it means you can't give birth vaginally. If you take and the angle is something like 70, just like a man, less than 90, you can't give birth naturally. So these are some of the factors. Modification between male and female pelvic. The angle is one of it. So if a female, if you want to assess in preconception, if you want to assess these things in a lady or in a woman, a scan or an X-ray will show you the angles. And then you can easily know that for this lady, she can't give birth vaginally in preconception. Okay. So there's a lot to do. Some of them you've heard it before, but you never put it in perception. This time, I want you to put everything in perception. So when you say the outlet, the inlet, first pelvis, through pelvis, please, it's in front of you. Okay? From the ischial spine to the ischial spine, we call the pelvic outlet. So when I say females tend to have a broader pelvic outlet as compared to men, you know which distance I'm talking about. Okay? So this is the same thing, looking at the part. This is the vinegar cap. Vinegar cap, also known as the acetabulum. This is where all the three bones join. Okay? We can see the tuberosity very rough, the pubic ramus, okay? And then the superior pubic ramus. That's the inferior, this is the superior, okay? And then together they help to form the obturator foramen in osteology or obturator fossa in the living. Okay. So this is a quick revision of what you've done already, but vis-a-vis what you expected to do. So this is the comparison between male and female pelvics. Okay. We can see male less than 90, females 100 or more. Pelvic outlet broader, pelvic outlet here very small. Even the shape and the slender aspect of the pelvic give difference between male and female. Okay, so when you compare the male and female pelvis, it means that if I show you as an X-ray, you can look at the X-ray and tell me this is a male X-ray or female X-ray. I hope you can do that. If I give you an X-ray of a pelvic bone, you can look at it and tell me that this is male or female by giving me reasons.
Yes, sir.
Yes, that's what I'm talking about. So the X-ray will show this way, and then you need to look at the angle, two areas, the outlet and the angle and the shape, and then look at this. Okay, the inlet, the shape, the angle, the outlet. Okay. Now this is for childbearing modification. Childbearing modification. Okay. If a lady needs to give birth or want to give birth vaginally, these are what it needs to go on, the modification. The second part will take us through the muscles. So please look through the muscle. In our next lecture, we're not going to talk about it. Look through the muscles. You are all here today. Now listen carefully. Go through the muscle. In our next lecture, you ask me a question. I will spend 30 minutes on the muscle, their clinical use. Their clinical use, what happens during this, what happened during that. Look at that in that perception. And then we go to the second part of it. So that we'll be done with the pelvic, and then we take the reproductive system itself. Male first, female first. We're going to approach it grossly, microscopically, and then clinically. Okay? Grossly means things that you can see in reproductive system of male and female with your naked eye. Microscopically, those that you can't see with the naked eye, like the endometrium and all this, we're going to talk about it. And then, of course, the sperm count, sperm analysis. These are all microscopic aspects. And then we move on to the clinical use of all this, so that in later, when they give you somebody's semen analysis, you can compare and contrast and tell me that, oh, this person is potent. It's not always about the sperm count. That's why some midwife will do. They always go for sperm count. Please, the pH, the viscosity, the everything, the morphology of the sperm always count. Okay. So in our next meeting, it'll be more interesting, and then more clinical approach. It will be looking at all things that.
Agnes Entry, please.
Agnes
mute your
Entry.
mic.
So what you are doing, is it nice? Is it fair?
Wait, so all what I said, was I couldn't hear me or it was muted?
We heard you, sir.
Okay. So please, that is how we're going to go about it next week. Okay. So next week, most of these things will be in that manner. Okay. So please read on the muscles. Go through the muscles yourself. Go through the muscles. Okay. Look at it, and then we start the male, and then possibly, if you have time, look at the female. So that within 2-3 weeks, we'll be done with the revision, and we start embryology. Any question? So if you look at it, the end of the lecture is very here. So muscles, don't spend more time on it. Next week, we're going to spend just 30 minutes on it, and then move to the male. So I'll load some videos, and I'll load the male reproductive system.
So they please mute your mic.
It's Ali do. Oh.
Any question? Any question? Any question? Okay. In absence of any question, Kamale, hey, why do you have any question? Why? Or what we did today? Why? Question, suggestion, anything? Why? Why? Okay. Kamale, any question? Suggestion, contribution? Kamale?
No, sir. No, sir.
Good. Akimoda?
Sir.
Akimoda? Question,
Sir.
contribution?
Please, no, sir.
Okay.
No,
Kita. Kita girls. Kita.
No,
Question,
sir.
contribution?
No, please.
Asanko. Kwa?
No,
Any?
please. No,
Okay.
sir.
Kufuria flowers. Kufuria flowers, girls. Koftan.
Sir.
Question, contribution?
Sir. No, sir.
Okay. Warukodo girls and men, if you are there. Any question?
Any question? Here.
Okay.
Okay.
Hello, sir.
Hello.
Hello, sir.
Yes.
Sir, please, I would suggest that when we come in, at least if we get more than 200, let's start. Today, we wasted like about 45 minutes waiting for others to join. I don't think this will help us to move forward. Aside that, I think you can kindly mute everyone for us.
Senna,
Because the class was so noisy.
You see, your host is not me. Your host is in Garden City. Now they create the page for us and they make us co-host. So at times we don't control much. And then the one managing is one person from Friday to this. He will be tired. So that's one of the challenges we are getting. It's not me, it's not only here, but you, the lecturer, if you can't control much because the host is somewhere else. They make you co-host. Okay. But for the starting point, next time I won't wait for anybody. If I come as one person, I start. Okay. So please, those that had bad weather and everything, next time in our meeting, I won't wait for you. So if your weather is bad, join early. This morning, I joined 30 minutes, I think 15 minutes before time, so that I can see what was happening, but people were not there. Okay. So please, and when you leave a one meeting, join the other one and then wait to go and rest. Don't wait for the lecturer to come and join. Join, and then you can go and do your thing. When I come in, you just come in. But don't leave and then wait for me to come before you come. Next time when I enter and it's time I start, I don't go back. Okay. This time I just went back for you to come. That's why. Okay. And then the controlling thing, please. This is a final year class, for God's sake. If you know you are in the, I told you the other time, if you're at work, you're at home, meet yourself. It's simple instruction. Now, some of you, I don't know. If it's the phone that you don't know how to use, if the phone was given to you yesterday or what, I don't know. Okay. So please, let's do it that way. So that, because we, the lecturers, are not hosting the whole thing. The only thing I can do is to meet everybody. And I'll be the only one talking, but that's not lovely. So at times I have to let you talk so that people can get different views of the same story. But if I'm supposed to meet everyone and talk, that's not class. That's not a lecture. That'll be torsion. I don't want to make it boring. So I always let you talk and test, but you need to comport yourself, please. Okay. Americans, any question? Americans?
Yeah. No, please.
No, please. So in the absence of any further question, discussion, suggestion, then I'll move this lecture to an end and then we meet next time. Thank you very much for your participation.